Hi, everyone. My name is Jim McKee. It's really a pleasure to be with you today. And really what we're going to talk about is the easiest way to attract high quality new patients to your practice. What we're going to do though, let's start out with a question. And let's assume that you were going to design your ideal practice. How would you design it? You know, and I thought about this, and really, I think if I was going to design a new practice or I'd want to do an ideal practice, I'd like to have a steady stream of new patients calling the practice. And what I'd like to do is I'd like to have those patients who were calling the practice be ready for treatment. So I'd be constantly busy in the practice. Ideally, if I was going to build my practice, what I'd like to do is I'd like to have patients who are willing to work outside the insurance system. So I could have a fee-for-service practice and not necessarily be constrained by the limitations that are put on by third parties in our discussion with patients. I'd like to have a steady stream of patients without really trying, so I don't want to have to do a lot of marketing for it. Ideally, I'd like those patients to be referred by dentists in our community. So there were dentists who would screen these patients, and it would be perfect if I had an unlimited number of dentists in the community who'd like to refer patients to the practice. Now, in terms of your fees, are going to be based on time and material costs, and they're going to be above significantly what usual and customary fees are going to be allowed by insurance companies. Those higher fees are going to allow you to use better labs, which is going to decrease the stress in your practice. It's also going to leave you enough time with patients so you're not rushed in your schedule, which is also going to decrease the stress in your practice. You're going to collect almost 100% of what you produce because your patients are going to value your services. You're going to be able to pay your staff a higher wage on a per hour basis than any practice in your community. And you can create a bonus system through retirement planning funding for your staff that they won't be able to get anywhere else. Your staff benefit package and your office culture is going to encourage long-term employee retention, again, which is going to decrease overhead, as well as the managerial stress that you have. You're going to be paid a fair salary throughout the year. You'll be able to fully fund your retirement plan along with personal savings. You'll generally see patients 3 to 4 days a week and use another day a week without patients for treatment planning and meeting with your referring doctors. You'll generally work 14 to 16 days per month. You have 4 to 6 vacation weeks a year, along with regularly scheduled continuing education. Your practice is going to have a high valuation due to the fee-for-service nature of your practice. Your practice transition is really going to be easy since it's going to be a highly desirable practice for young dentists because it's fee-for-service and it's profitable. And this type of practice is going to allow you to mentor younger dentists and allow you to work at maybe a reduced pace as you transition your practice. Now, people are saying that sounds great, but that's not really realistic. I'm going to tell you that is realistic. That was basically the story of my practice for 35 years. And the question is, how do you create this type of practice? You become confident treating occlusion and TMD patients. And as soon as I say that, the pushback I get is, I'm not very confident treating occlusal or TMD patients because I didn't really learn it well in school and I don't understand it. And besides, I was told those patients are crazy anyway. I don't want to treat them. So let's take a closer look at this. Why are most dentists not confident in occlusal and TMD patients? Number one, we took too small a view. We limited the definition of occlusion to the tooth level. Take a look at Jennifer here. When you take a look at Jennifer, usually we're going to look at, is she a class 1? Is she a class 2? Is she a class 3? Edward Angle developed that back in 1899. And that's generally how we look at patients' occlusions today. So when we look at her, you can see she's a class 2 occlusion, but really what we're simply doing is looking at the tooth level. I'm going to suggest that we redefine occlusion, because if we redefine occlusion as how the lower jaw fits to the upper jaw, it all becomes a lot easier now. And ultimately, we're going to look at how her teeth fit together. But if you think about the anatomy, the back end of the system plays the same importance as the front end of the system. We've got a condyle disc that has to fit against a socket on the right side and the left side. And when you start to take a look at her, she's an interesting case. because all of a sudden you're going to start to take a look at some way the teeth are fitting together in her skeleton. We're going to come back and take a look at this case in a little bit. But here's what I want you to think about occlusion. Don't get hung up on right side or left side. Don't get hung up on the joints or the teeth. Just think about the lower jaw fitting to the upper jaw. Now, the second reason, we made occlusion way too complicated. Ultimately, occlusion is about force distribution. The muscles are positioned between the teeth and the joints. Force is going to be distributed between the teeth and the joints. So at the tooth level, we want to have even posterior tooth contact, even intensity, simultaneous contact. We don't want one tooth to hit harder than the rest. It increases the chances it'll break, it'll wear, it'll loosen. We want to distribute the load over all the teeth. On the anterior teeth, we want to have a non-restrictive anterior guidance. I heard anterior guidance when I was learning occlusion as having the front teeth contact and the back teeth separate. I didn't really understand a non-restrictive anterior guidance until I looked at Jim. Jim was a patient who I treated. He has a force distribution problem at the tooth level. Here's the question from a treatment planning perspective. Let's reverse engineer this case. Why did these teeth need to be crowned? They were worn. Look at the gingival levels. You can see the incisal edges wore. There was dental alveolar compensation and the teeth dropped. Now, I was only 2 years out of dental school when I saw this, so none of this was on my radar. Why did I tie those crowns together? Because right now, that's 5 porcelain fused to metal crowns from lateral to canine. I splinted them for retention. The teeth were short. I was afraid they were going to fall off. But if you also look what I did, I created a stepped anterior posterior occlusal plane. The anterior teeth are longer than the posterior teeth. Well, that was for aesthetics. It had to be a width to length ratio that looked like a tooth, because otherwise it just would have looked like the teeth that he had originally. I didn't think much of it until he came back in for a cleaning appointment 2 years later, and I about fell out of my chair. When I looked at the lower anteriors, they didn't look like that when the crowns went in. And right away, I started to think I didn't really understand anterior guidance. What I did is I created a restrictive anterior guidance. I created a pathway wear case, as Frank Spear talks about. And the question is, there is enough room behind the upper front teeth for the lower front teeth to be able to function? There wasn't. I under-reduced the upper anterior teeth, and the lab technician filled in the lingual surface. So basically, I filled in all that room that those lower incisors had to function, and then they just got torn up against the porcelain. So the treatment planning perspective, probably think about moving those teeth back to where they were originally. We want to increase the overjet to provide more room for the lower front teeth to be able to function, but we want to verify this with provisionals. I didn't do any of that. So if we could think about making sure that we have a prototype when we're doing these types of cases, now we can work all that out ahead of time. Now, that's force distribution at the tooth level, and that's what we're used to talking about. I'm going to suggest we think about force distribution at the joint level as well. In order to do that, let's look at some imaging. I'm going to show you a CBCT view, coronal view, so that's a front view. So you're looking straight on the condyle. Lateral and medial orientation. Lateral's the part you can feel when you open and close right in front of your ear. Medial is 20 millimeters in towards the brain. Condyles outlined in red, joint sockets outlined in yellow. No disc because CT only picks up hard tissue. So I want you to take a pencil in your mind's eye and draw a normal disc shape in. Is there enough space? Is it compressed or is it normal space? This is a good example of normal. Here's what the MRI is going to look like. Same orientation, condyle, joint socket, and then we can fill the disc in. Above the yellow is brain, below the yellow is joint. Here's the view we're more used to looking at, the sagittal view. The CT scan, now we've got an anterior posterior orientation, condyle in red, joint socket yellow, again, no disc. Same exercise. Take that pencil in your mind's eye, can you draw a normal disc in there? That's pretty good joint spacing. Now, we'll look at the MRI. We'll fill in again, joint socket yellow, condyle in red, disc in blue. And now it gives you a real good idea of what normal joint anatomy looks like when we're talking about force distribution at the joint level. Because don't forget, the muscles sit between the teeth and the joints. Force is going to be distributed between the teeth and the joints. So, couple things to understand. In the anatomy, the joint socket, the medial aspect of the joint socket is really thick, dense bone. It's perfect for load distribution. So medial pole's the load-bearing part of the joint. So when we think about that, when we think about load distribution, let's think at the tooth level. If you look at Troy was a long time ago case. Troy had worn his teeth. Actually, it was pretty similar to the case that I showed you that I did the grounds on. I had recommended a full mouth rehabilitation. Fortunately, Troy said no. I was really over my ski tips on this case. But again, here it's easy to see that the occlusion's overloaded at the tooth level. At a 34-year-old to have that type of wear, obviously that's not a stable long-term solution. But how do we look at it at the joint level? Now, let's take a look at Mary. This is in different cases. This is a 21-year-old. Are the forces overloading the occlusion at the joint level as well? Take a look at the outline of the bone, and I want you to think of that condyle like an M&M. Hard shell outside, soft inside. The white line that goes over the top of the bone on the left condyle is a pretty good example of a normal cortical plate, where I just outlined with the red arrows in the right joint is a good example of unstable bone. That cortical plate is broken down. The shell on the M&M is cracked, is the way I'll explain it to patients. So when we start to think about simply occlusion in terms of how the lower jaw fits to the upper jaw, and are we overloading forces at the tooth end or at the joint end, everything becomes much easier. So for the rest of this presentation, let's look at two questions. One, how do we make sense of occlusion in joints? And secondly, how do we treat problems with these types of patients with these types of problems? So let's talk about joint condition, because normally if we want to understand occlusion, the easiest way to understand occlusion is really to understand the joints. So we typically talk about joints as being normal or disc displacement with reduction. That's the clicking joint. A disc displacement without reduction, that's the joint that used to click but doesn't anymore, or the perforated joint. That's where it's bone against bone. That's normally how we refer to joints. Problem is, it doesn't talk about the disc coverage at the medial pole. So ultimately, we can't assess risk factors in treatment planning. If the disc does not cover the medial pole, risk factors are going to increase. So we want to look at a joint classification system that really looks at the medial pole. So as a restorative dentist, I know how to communicate the risk factors in case to the patient and any of the specialists that I may be working with. So I'm going to provide a joint classification system that looks at three types of joints. The first are structurally intact. This is a top view. The disc attaching the bone at the lateral pole is intact, same at the medial pole. This is a normal joint. Second is structurally altered at the lateral pole. The load-bearing part is still attached well. The outside part, the ligament is torn. And then lastly, we're going to have structurally altered at both the lateral and medial pole. So if we think about it, the structurally intact joints have very low risk factors. They're basically normal joints. We can do anything we want. The structurally altered at the lateral pole are green-yellow cases. We still have load-bearing protection at the medial pole, so we're not too worried about these cases. The higher risk cases are the yellow-red cases. Those are the cases that tend to be the more difficult ones to manage. Now, in the green cases, we're going to have normal soft tissue and normal hard tissue. In the green-yellow, basically, we're going to have a partially herniated disc attached on one side, off on the other. We're not sure about the bone. We're pretty sure the bone on the medial aspect is going to be good because it's still protected, but we're not sure about the lateral aspect. Now, in the yellow-red cases, the disc is off completely. So that's a completely herniated disc, and we don't know about the bone. It may or may not hold its normal shape. It may or may not hold its normal position. Everything's kind of up in the air there. Honestly, that's why they're yellow-red. There's more risk involved in those types of cases. I never heard it quantified like this looking at joints, So joints were always one big mystery to me. For those of you who may be familiar with the Piper classification, Mark Piper's an oral surgeon who's retired, came up with a classification system many years ago that talked about Piper stages 1 and 2 being the green type joints. Piper 1's completely normal. Piper 2 just has a little bit of strain on the lateral aspect. Not a big deal. The green yellows are the Pipers 3A and 3B. 3A is a lateral pole click, so that's a disc displacement with reduction at the lateral pole. 3B is a disc displacement without reduction at the lateral pole. And then lastly, we've got the 4s and 5s. If 3A was a disc displacement with reduction at the lateral pole, 4A is a disc displacement with reduction at the medial pole. 3B was a disc displacement without reduction at the lateral pole. 4B is a disc displacement without reduction at the medial pole. And then the 5s are perforated. Those are bone to bone. A is acute, sore. B is chronic or adapted. Easy way to be able to communicate the type of joint you're dealing with your orthodontist, with your oral surgeon, with your periodontist, with your lab technician, any person that's involved in the case, your ENT, your pain physician. The yellow, or the green and the green yellow, those are the lower risk patients, lower risk for dentists, because generally those cases are going to be easier. We don't see as much pain. We don't see as much bite change, and we don't see as much compressed pharyngeal airway space. So these are the patients. We don't need to image these patients. We're going to be aware of treatment planning when we're thinking about the joints, as Frank Spear talks about, but we can use indirect visualization. We don't have to see the anatomy. Now, if we have normal joints like we're talking about, usually what we're going to have is we're going to have normal vertical dimension. And you know, it's interesting. I'm going to talk about vertical dimension at the tooth level, because normally that's not how we hear about vertical dimension. Usually we hear about vertical dimension at the joint level. Or excuse me, I'm going to talk about vertical dimension at the joint level because usually we hear about vertical dimension at the tooth level. At the joint level, vertical dimension is comprised of the disc, which is approximately 2 millimeters. And we've got hard tissue, let's call it ramus length, which is going to have a range of probably anywhere from 60 to 75 millimeters. So that's going to be the vertical dimension that we're going to be looking at in terms of the joint level. Let's go to the yellow reds now. These are the higher risk cases. A couple things I want to talk about just to make sure that we're clear on this. The medial pole is the load-bearing portion of the joint due to the anatomy. We talked about the bone there. So what we want to do is we want to make sure we have a disc covering the load-bearing part of the joint. If the disc is not covering the medial pole, as it doesn't in the yellow-red cases, the risk for pain increases simply because we don't have soft tissue protection. That's the first thing I wanted to say. The second thing I wanted to say is think of the disc at the medial pole as a gasket. A gasket is a softer material between two harder materials. Think of the plastic on the inside of your refrigerator door that holds the cold air in. The disc is kind of the same thing. It's a soft tissue material that positions the condyle three-dimensionally in the joint socket. So we have a bite that closes to the same place every time. If the disc is not covering the bone at the area where it maintains the vertical dimension, we have an increased risk for a malocclusion. Now, there's one other thing we want to talk about. If the disc isn't covering the bone in the growing years, we have an increased risk that the bone doesn't grow completely. If you take a look at this case, the ramus length on the right side is almost 53 millimeters, and it's 58 on the left side. You've got a 5 millimeter ramus length discrepancy, pretty significant when you start to take a look at the occlusion and the facial aesthetics on this case. We're going to come back and take a look at this case again in just a second. These are the cases that are high risk for patients. These are the higher risks for dentists, quite frankly, because we're not aware that we're treating these types of problems. There's more pain in this population. There's more malocclusions in this population. We also have a higher risk for compressed pharyngeal airway space. We're going to take a look at airway in just a couple of minutes. This, we're going to have directed joint treatment planning. which means we're going to look at the anatomy with MRI and CBCT scan. These yellow reds, we have to see what the anatomy is in order to know how to treat this. We talked about vertical dimension. Let's go back to the tooth level. Here's the question. Usually in a wear case, the question is, how many millimeters are you comfortable opening the bite to restore a worn tooth? Normally, 1 millimeter is okay, 2 millimeters okay, 3 millimeters people start to get a little uncomfortable. 4 millimeters, most of the hands go down, but they don't want to open in 4 millimeters. I'm going to tell you from a vertical dimension discussion, we're looking at the wrong end of the system. When we take a look at the vertical dimension at the joint level, we're going to see 15 to 20 millimeter bone deficiencies that we were never aware of until we had three-dimensional imaging with CBCT to be able to measure the ramus lengths. So ultimately, it's due to one of two issues. It's a failure to maintain, which means it grew normally and then broke down. I used to think that was the majority of the cases. I don't anymore. Today, what I think this is a failure is it's a failure to grow normally. You know, it's interesting. Jeff Rouse and I are going to do a webinar tomorrow titled, Are We Treating the Same Patient? And what Jeff and I have come to realize is that basically we have an epidemic of not only airway issues in children, but joint issues in children as well. So as much as we are tuned into this airway issue in kids, we have to also be tuned into the joint issue in kids as well, because many times it's the same patient. So when we start to take a look at things, here's really the easiest way to think about it. As bone decreases, risk increases. Pretty much the same as any other treatment planning discussion we have in dentistry. Whether it's periodontal support, whether it's implant bone, it's the same at the condyle level. When the bone decreases, the risk increases. So these are the deep end of the pool cases. How do these present in our practice? Easy. Some of them hurt. That's the way we've defined TMJ. I'm going to tell you that's end stage. The earliest way to pick this up is that something doesn't fit. And usually it's a change in vertical dimension, either at the soft tissue or the hard tissue. So when it comes down to it, when we really talk about things that don't fit, the most common thing in occlusion that doesn't fit is the class 2 occlusion. Take a look at Isabella. She's 13 years old. Look at the retrognathic mandible. Right off the bat, we know the mandible's not projecting out far enough. And now when we look at the imaging, we can understand why, because we have a lack of soft tissue protection while the bone's growing. If we look at the literature, 2016 in the systematic review of literature, Daniel Manfredini from Italy talks about it's reasonable to suggest that skeletal class 2 profiles and hyperdivergent growth patterns are likely associated with an increased frequency of disc displacement and degenerative disorders. Years earlier, 10 years earlier, Carlos Flores-Meyer from University of Alberta in Canada talked about disc abnormalities is associated with reduced forward growth of the maxillary and mandibular bodies. Disc abnormalities associated with reduced downward growth of the mandibular ramus, exactly what we've just been talking about. Let's go back to Jennifer. We looked at this case to start our presentation. Jennifer's 28, she's the class 2. She also has a canted occlusal plane though. Now, for those of you who are paying attention early in the seminar, when we looked at her three-dimensional imaging, what we started to see is the canted occlusal plane. Now that we've talked about this, I'm going to suspect that there's a right ramus length issue as well when we start to look at things. And this is the Panorex from the CBCT that we looked at earlier. 53 millimeters on the right side, 58 millimeters on the left side, a 5 millimeter difference. That accounts for the canted occlusal plane. That accounts for the facial asymmetry. That explained basically the reason for her office appointment was because she was unhappy with her facial aesthetics. She didn't have pain, but she didn't like the way things fit. She didn't like the appearance of her teeth. She also had a midline discrepancy, if you remember from the earlier picture. The facial asymmetry, again, this is another patient. This is Karen. This is facial asymmetry the other way. When you now look, you can see the chin deviation on the previous patient was to the right. This is a chin deviation to the left. So now when we start to take a look at the left joint, we can see there's compressed joint space in the right joint, Remember I said, take your pencil and draw that normal disc? We can't do that here. We've got compressed space there, so there's no room for a normal disc. Now, on the left side, that's a totally different story. We don't have normal bone there. We didn't get normal growth there. Again, that's why everything is shifted to the left. And when we take a look at the ramus lane, 64.5 on the right, 52.3 on the left. See what I mean about vertical dimension at the tooth level versus the joint level? This is where the action is in terms of vertical dimension. It's at the back end of the system, not the front end of the system. Anterior open bites, you know, every dentist has watershed cases in their career that indelibly mark them. This was one of mine. I saw this patient. She's a wonderful patient. I diagnosed her as having a tongue thrust because at that time, that's what I was learning was opening bites. Once I started really starting to image more and take a look at vertical dimension of the joint level, really it became obvious that the reason why the anterior teeth didn't couple was not because the tongue pushed the teeth apart. It's because the condyle didn't grow normally because the ramus lane was short. And now when we take a look at the size of the bone in this joint. This bone doesn't, the normal bone should fill 2/3 of the joint socket. That bone is small bone, which typically means the disc came off before growth was complete. We've got a large disc sitting right in front of a bone, can't open real wide. It's like a doorstop that wedged in there. If you look at the slide all the way on the right with the red oval around it, what that's showing is swelling inside the marrow space. So basically, if you think of the marrow space inside the condyle like a dental pulp, innervated, vascularized, encased in a solid structure. Anytime there's inflammation in a pulp and it starts to swell, it starts to hurt. Same thing here. The bone starts to swell internally and starts to hurt. What were we taught caused most of the pain in TMD patients? We were taught muscle. That's because we didn't have the advantage of three-dimensional imaging that we have today. Today, we know that while muscle is a component in a lot of these cases, there's way more patients that have the hard tissue issues that we talked about, or upper cervical spine issues, or other issues that we'll talk about in just a second, that help explain why they have pain. They're not crazy like we were taught. Overjet problems, again, from an orthodontic perspective, are hard cases to treat. And many times it's because simply the teeth can't fit together at the front end of the system because they've lost or failed to achieve normal dimension at the back end of the system. And again, if you take a look at this case, this is another really good example of an unstable joint. Take a look at the shell again on the M&M. The shell is broken down on the right side. The shell is broken down severely on the left side. This is something you want to know about before you start orthodontic treatment, because that's the reason the patient came to your practice. I said, I want you to refer me to an orthodontist because I want to get my bite to fit. It would be nice if we could take images of this patient before we send them to the orthodontist and say, here's what we're dealing with. What's our best way to handle it? We're going to see posterior wear cases. You know, again, another interesting case. Mary's 17 years old, huge open bite, just finished orthodontic treatment, but she says the reason for her appointment is her lower second molar is starting to hurt. Take a look, that's worn all the way through the enamel because basically that's the only thing that's touching. But take a look at the condyle. When you take a look at the condyle, that's a really skinny condyle. So not only is she a wear patient, a pain patient, a joint patient, what else is she? She's an airway patient. Look at the CBCT. The compressed pharyngeal space is obvious because the mandible simply didn't get out far enough because it didn't grow. Retrognathic patients, another interesting case. If you take a look, Mackenzie's 10 years old in the picture on the left. Look at the retrognathic mandible. Anytime you see a retrognathic mandible, start to think that they're not growing well. I saw her at age 16 years, 10 months. You can see the left condyle really didn't grow very well at all. But again, we'll see these high angle, mandibular plane angle cases like Skip, another retrognathic mandible. You know, it's interesting. They're kind of all called the same cases. They're called vertical growers. They're called clockwise growers. But basically, so many of these patients are airway patients, basically because we can't get out far enough again. Look at again the compressed pharyngeal airway space. Let's talk for just a minute the impact of structural changes on the joint on the airway. So let's look at the soft tissue changes. Normal disc position should be at 1 o'clock of posterior disc. If the disc starts to slip because the ligaments start to tear and the disc comes forward, it goes to a 12 o'clock position. Now the condyle is resting against the thickened part of the disc. It's actually a class 3 bite shift, which is airway positive. Problem is we don't have a lot of those joints. The more common presentations are the 11 o'clock joints. That's a class 2 bite shift, but take a look at the condylar position as well. See how that disc is pushing that condyle back in the joint socket? That's dragging the lower anteriors back, causing a class 2 bite shift, but it's also compressing, moving the whole mandible back, so it's airway negative. Same thing happens with the 10 o'clock disc, where now the condyle is almost bone against bone, another class 2 bite shift, and another airway negative bite shift. Now, the clinical reality is there's more 10 and 11s than there are 12s. So most of the time, if we have a disc that's displaced, it has a negative impact on the airway. Same thing with bone. If we have an increased ramus length, like we see on the ramus on the right at 77, that's a class 3 bite shift, and that tends to be airway positive. We're more likely to have the class 2 bite shift. 48.4, again, huge ramus length discrepancies. This is on the McKenzie, the 10-year-old and the 16-year-old we just looked at. You can see that short ramus length didn't grow. And when that happens, we start to lose airway space. I'm going to show you 5 quick cases. Here's Christine. We already looked at her imaging, but now when you look at her imaging, her ramus length you can see is short as well. And now compressed pharyngeal airway space. I want you to start to link decreased ramus lengths with an increased risk for compressed pharyngeal airway space. Here's Paula. Again, small condyles again. You have to suspect that the disc came off before growth was done. 54.6 on the left, 54.6 on the right, 53.4 on the left. And now again, another compressed pharyngeal airway space because of the short ramus length. It simply wasn't able to get far enough. Here's John. John's a big guy. John's about 6'4". Again, bad bone on that right side. The shell of the M&M is really broken down in this case. Ramus lengths are almost 62, 63. He should be up near 70, given his size. Compressed airway space again. And you can see the uncoupling of the anterior teeth. It all starts to fit together when we start to look at vertical dimension at the joint level. We look at Sherry again, pretty unstable bone as well when you start to look at that. Again, short ramus lengths, compressed pharyngeal airway space. And lastly, Leah. Leah's really retrognathic. So again, I'm suspecting a shorter ramus length than her. She's 54 and almost 55. And again, really tight airway spaces. You know, it's interesting. Airway gets so much attention today. And ultimately, we've always talked about the maxilla. This is a great article published in 2021 that finally talks about airway in relation to the joints. Recent studies have shown individuals, both male and female, with steep mandibular plane and dolichofacial characteristics, another name for a short ramus length, that are higher risk for having joint disorders and altered skeletal morphology. Decreased ramus length and decreased posterior face height, clockwise rotation of the ramus and the mandible. Basically, it's reasonable to postulate a developmental onset of degenerative joint disease can limit airway dimensions. We know mandibular growth is linked to condylar growth, and if we have structurally altered joints in kids, as we talked about earlier, they don't grow well. So ultimately, airways become narrower secondary to joint change. You know, when you think about it, the airway world typically emphasizes the maxilla. I'm going to tell you today, I don't think you can treat airway patients without understanding the soft and hard tissue of the joints. Having seen the joint anatomy in those 5 patients, how would you feel about making them a mandibular advance appliance to try and help any sleep issues they had? Those are all potential recipes for disaster given the condition of those joints if you make an appliance that pulls them forward without protection given their bone condition. So today, if you're going to think about doing sleep appliances, try to have a pretty good idea of what's happening at the back end of the system as well. In my experience, the number of hypoplastic maxillas and mandibles are both underestimated. It's not just the maxilla, it's the mandible as well. The number of patients who could benefit from maxillary and mandibular surgery is underestimated. That's the reality. The other reality is the number of patients who are going to do surgery is low. So what that comes down to is both, as the dentist, we need to understand the limitations that are put upon us by the anatomy, but so does the patient. Ultimately, hypoplastic hard tissue anatomy, either maxillary or mandibular, may result in a compromised treatment outcome. We have to be comfortable with that, and so does the patient. Now, a lot of times I'm going to hear dentists say, I really don't treat joint patients or TMD patients. Why do I need to know about the joints? Here's what I'm going to tell you. You can choose to opt out of treating pain patients. And again, I made most of this presentation about occlusion because I really think that's where we see this. But here's the issue. We treat TMD malocclusions every day. And what I want you to start to think about is I want you to start thinking about a compressed pharyngeal airway space as a potential clinical manifestation of a structurally altered joint. All these patients are in our practice. You know, the problem is we always think this is about pain. Pain typically is one of the last things that occur. Most of the malocclusions that occur are a result of a failure to achieve normal or a failure to maintain normal. But the longer I do this, the more convinced I am that people just didn't grow well because it happened earlier than we thought. So joints are a key factor with or without pain when you're looking at class 2 occlusions, Canada occlusal planes, facial asymmetries, anterior open bites, deep bites, overjets, wear cases, gummy smiles, retrognathic patients, vertical growers, high mandibular plane angles, airway patients, and pain patients. That makes up a lot of our day. How many of these patients are in your practice? We were told it was 5 to 10%. Today, we know it's closer to a third to half. And especially if you're watching this webinar, generally it means that you're tuned into treatment planning and you're looking to practice at a higher level. Patients are going to find you because they have needs that aren't being handled at other practices. So I think that this isn't something now that we make about pain. Think about this from the bite. So that's making sense of the joints. Let's talk for a couple minutes on how to treat this to kind of wrap things up. Let's talk about treatment plannings both at the maxillary and the mandibular level. Now, maxillary options, we can try to solve transverse problems or AP problems. Mandibular options at the joint level, we can have phase 1 indirect options where we're not doing anything to the joints, or we can have surgical options at phase 2. So in terms of maxillary options, we can do traditional maxillary tooth expansion and tooth uprighting on the mandibular. We could do surgically facilitated ortho. We could do MARPI. We could do dome, or we could do SARPI. Those are all options today to try and gain transfers with, again, because what we're trying to do many times is to treat nasal obstructions by increasing the surface area or the nasal floor to be able to increase the amount of nasal breathing we're able to do well. Anterior posterior options could be tonsils and adenoids, could be some type of tongue therapy with myofunctional treatment. You could use ortho with some type of headgear. Again, we can get AP change with SFOT, or we could do a skeletal orthognathic procedure doing a Lefort to move the skeletal bases. Now, those are the maxillary options. The mandibular options, probably the most common, is an appliance. We can add physical therapy and chiropractic treatment to that. We can use pharmacology, muscle relaxants, anti-clenching, nerve conduction medications. We could use injection therapy, diagnostic nerve blocks, Botox, platelet-rich fibrin. So there's a number of different options out there today. If we're going to go directly at the joint, we can do soft tissue or hard tissue options. Soft tissue may be an arthrocentesis to flush the joint. Arthroscopy is putting a camera in to take a look. A disc repair would be to put the disc back on top, and a disc replacement would be to take it out and replace it with abdominal fat. Hard tissue options are reinforcing the bone with a rib. or replacing the joint with total joint replacements. Now, that's looking at the bone level. If we go to the tooth level, generally we're going to follow facially gendered treatment planning that Frank Spear talked about in 1986, working through setting the central maxillary central incisor, making sure we've got correct axial inclination of the maxillary central, creating our occlusal plane that's level so we don't have a stepped occlusal plane like I talked about earlier. We'll make sure we have ideal gingival levels, and then we'll go to the bottom. We'll make sure our incisors are level. We'll make sure they're at a correct axial inclination so we can get a nice anterior guidance that's not restrictive. We'll make sure we have a level occlusal plane. And again, we'll look at our gingival levels. Our tools to be able to do this are equilibration, orthodontics, restorative, or orthognathics. Reshape, reposition, restore, resect, or move the bony housing of the teeth. So it's a real easy way to organize your thoughts pretty much for any case that we're going to treat. And that can be airway as well. If we're not going to do anything, we could include a CPAP in that discussion for an airway patient. But otherwise, the treatment options that we talked about can be applied to the airway discussion as well. Phase 1 options we talked about. And basically what we're doing with those is we're going to change joint loading and we're going to hope for adaptation at the joint level. We're not changing anatomy, we're just changing the way the load is applied. And fortunately, these cases work out really well for a lot of patients. I've done a lot of phase 1 therapy over the years. It's been extremely successful. We can do this on any stage joint. Phase 2 are going to be the hard and soft tissue options that we talked about. And really, when you talk about it here, what you're doing is you're changing the anatomy in the joint. And again, you're hoping for adaptation. I want to say that because I want us to understand this is structurally altered. This isn't factory new parts. We're hoping for adaptation at the joint level by doing this. These are going to be done generally in the yellow-red cases. There'd be no reason to consider this that I could think of in a green or a green-yellow case. So the question is, when should you really consider this? 3 times to think about it. 1, if you can't get the patient comfortable with anything that you've done, appliances, ortho, equilibration. A lot of times that's disc replacement with support of the occlusion at the tooth level. The second is you've got small condyle patients. We used to do rib grafts. Today, it seems like total joints, because we're able to make those so much more accurately today, have kind of replaced ribs. Usually when you do that, you're also going to do a disc replacement with fat and support at the occlusion at the tooth level. And the last would be growing patients. You know, there's one option out of all those that gets anatomy back to normal, and that's the disc repair. There's been a lot of studies coming out of Asia that have talked about the benefits of disc repair over the last 4 or 5 years. You're starting to see the pendulum swing back to doing more surgical repairs in growing patients to prevent the type of problems that we're talking about. So really the question is, who are the patients you may need this on? These are the yellow reds, or maybe really more the red cases. Large 11 o'clock discs that sit in front of bone, in my experience, tend to increase pain, tend to decrease the ability to move. Eroded bone hurts. Sometimes we can stabilize this with appliance therapy, and hopefully that shell of the M&M reforms. Sometimes it doesn't. Swelling inside the bone, like we talked about earlier on that case with the open bite. This is another case after an anterior deprogrammer was placed, the joint just blew up. Again, those are linked to pain pretty significantly. Small bone's hard. Small bone, again, it's not enough to carry the load. If you think about force distribution, basically it's like wearing high heel shoes and walking through wet grass. There's just not enough support there to be able to distribute the load. Short ramus lengths are tough because that compromises the airway, it compromises the occlusion, it compromises the aesthetics. Neurogenic pain many times is related to the structural breakdown of the anatomy, and airway anatomy sometimes what drives the discussion simply because patients have such compressed airway spaces. Now we have to think about doing something to try and reposition the upper and lower jaws. And if we're going to do that, we have to think about whether we have to do something to stabilize the joint before we look at those types of procedures. So those are the reasons you think about it. But I will tell you today, the pendulum is swinging. It's much more predictive than it used to be. We have far better techniques than we used to be, but basically the real advantage is now we can see it. We have MRIs and CT scans that we can use preoperatively to know exactly which patients should be considered for this and which ones really shouldn't be considered for it. Lastly, our phase 3 options are how to get the teeth to fit together. And that's, again, the reshape, reposition, restore, resect. Here, what we're doing is changing tooth position and condition. And now, again, same discussion. We're hoping for adaptation at the tooth level. And again, we can do this on any Piper stage that we'd like to. So ultimately, if you're a new dentist, this is without a doubt the fastest way to attract new patients to your practice and build a fee-for-service practice. If you're a dentist practicing 5 to 6 years out and looking to buy a practice, this is the fastest way to transition a practice, and you're not going to have to rely on patient retention if for some reason the patients decide to change their practice. If you're an experienced dentist and you're looking for a little bit more exciting dentistry, maybe become a little bit bored just doing class 2 composites, or you're looking to protect your patient base because it's eroding due to the influence of third parties in your practice and your patients, this is the best way to invigorate your practice. Ultimately, what we have to do is we have to redefine occlusion to include how the teeth fit together and how the joints fit together. I want you to hear this loud and clear. The yellow-red cases, the Piper 4s and 5s, can be treated predictably if the anatomy is assessed with MRIs and CBCTs. We're treating these patients every day in our practice. It would be nice to know which ones are the high-risk patients. Generally, the patients where the teeth aren't in the right place or you can't get them comfortable are typically the ones that fall into that category. Beware of the bites that we talked about, the class 2s, the open bites, the worn bites, the overjets, cross bites, the asymmetries, the gummy smiles, the deep bites, the airway patients, the canid occlusal plane, the locking jaws, pain patients. All those patients, and that makes up a lot of our patient base, have structural alterations at the joint level. I will make you one promise that I'm absolutely sure of. If you start imaging with MRI and CBCT, it will change your perspective on occlusion and temporomandibular joints. Your confidence level will skyrocket because you're going to understand occlusion and the joints at a higher level. The other thing is, though, here's the part I want you to understand. There are patients in your community that are looking for someone to do this, and they're going to work outside the insurance system. The other thing is there's dentists in your community who don't want to do this. Be the person in your community. I will tell you, really, we did no marketing, and we have more new patients than we could see, and it's been like that for the last 30 years. Even when the market went down during the recession and when the market was bad, our numbers didn't go down because, quite frankly, we had an unending supply of new patients. This is the fastest way to build a practice and attract high-quality new patients because no one wants to do it. Everyone wants to do Airway. Everyone wants to do aesthetics. Everyone wants to do implants. No one wants to do occlusion and joints. You know what? It's not that hard. This is pretty quick to do. You can implement these changes pretty quickly in your practice, and you'll have immediate benefits. Your acceptance level is going to increase dramatically because you're going to be more confident. Ultimately, your profitability is going to increase too, which is going to lead to decreased stress in your office and more personal time outside the office. So your stress level is going to decrease, your enjoyment level is going to increase because you're going to be more confident clinically and you'll be more successful managerially. So with that, what I want to do is to say thank you. I think we're right about on time. I do want to talk a little bit about Spear Online. Spear Online is basically an online discussion board that looks at cases, discusses managerial topics, discusses clinical topics. You have some of the top dentists in the country on this, in the world on this, quite frankly. It's a really great benefit. I'm on there a lot. I like those types of discussions. I just put some discussions up there regarding the advanced occlusion workshop. But Spear Online really is a fast way for you to get multiple thoughts on staff issues, on treatment planning issues, on how do you talk to patients, on how do you set your fees, how do you handle difficult issues in the practice. So it's a great tool. And again, it's all people who are similarly like-minded people. So you tend to have practice have similar patients or doctors, I mean, who have similar practice styles. So your answers are pretty strong for it. The workshops at Spear, really the online or the in-person workshops augment the online program so nicely at Spear. The advanced occlusion workshop is the one I taught. I just taught it a couple of weeks ago. I got to tell you, we get really nice reviews for this. You know, when you think about this course, it really, my goal in this is to make this as turnkey as possible for you. There's a lot of forms in there. There's a lot of letters that you'll send out. I want you to be able to go home and to be able to take this and implement it pretty much immediately into your practice. And dentists who have done that and really taken the material and gone back will come back routinely and say that it's impacted their practice almost immediately. The last one I thought was great because it's really not about just advanced occlusion. This is all patients. And the more we understand it, the more confident we can be. We're going to do that workshop again in September 28th to 30th in 2023, and then February 29 to March 2nd in 2024. Lastly, there's a webinar survey. If you could send that back, that would be great. And at this time, I would be happy to entertain any questions. And I see there are some questions in the chat room. Renelle, do you want me to throw it back to you, or do you want me to take care of these?
Either way is fine with me.
Tell you what, let's just start talking. First question is, what's a restrictive anterior guidance? That's a great question because that was a question I really didn't understand. So basically what it comes down to is a restricted anterior guidance is where there's not enough room for the lower anterior teeth to be able to function. I heard it explained as people have different chewing patterns. People can chew real vertically like a rat or real horizontally like a cow. The first case, he chewed like a cow and I built him like a rat. That's what happened. And the room that he needed to be able to function, I took up with the restoration, and that's why the teeth were. So I guess I would say a restrictive anterior guidance is where there's not enough room for the lower front teeth to be able to function without interference from the upper anterior teeth. So I hope I answered that question. Next question is, what program are you using to measure all these things? Basically, we're using In Vivo, or if you have an iCAD, it's sold as Treatment Studio. In Vivo or Anatomage is the third-party program, and if it goes through iCAD, I think it goes as Treatment Studio. It is the post-processing program for CT scans. There's different ones out there. That's the one we're using on this. I guess one thing I want to say on this, though, it's important to understand one of the things that we have to do is we have to post-process these scans. It's like getting a loaf of bread back from the bakery that's not cut. We need to make the cuts to see what we want to see. Now, that's part of staff training. My staff does those cuts. I'll do the MRIs, but it's an easy thing to do. But the program we're using is Treatment Studio. Next question, does a chin deviation or a canted occlusal plane always mean changes to the articular disc? Or can it be the result of different issues like muscle or upper cervical misalignments with a healthy disc? I'm cautious about always or never statements. So I'm going to say it doesn't always mean it's a change to the articular disc, but I will tell you in my experience, the correlation between chin deviations and canted occlusal planes on cases that I have imaged is close to 100%. I'm not saying that there are other things that could cause it, because those could cause that. But really, I think today, after looking at imaging for a long time, if I see a canted occlusal plane like that or a chin deviation, I'm pretty certain that it's going to be a joint-based issue. I've imaged a ton of those patients over the years, and I just don't see normal joints on them. So that's why I'm leaning towards to say that it might not be always, but it's going to be a really, really high percentage of the time. If given the choice, would you rather have an MRI or a CT scan? Many of us have CBCTs in our offices. Can you tell the joint position based off the bone? Great question. Here's the deal. MRI shows disc position, disc condition, and marrow condition. CBCT shows cortical plate, ramus length, airway, upper cervical spine. Now, there's other things they show, but thinking in the big picture. So when I say, would I rather have an MRI or a CT scan? It kind of depends on the patient. I know many of us have CTs in our office, but I guess I'm going to give you my perspective. I grew up on MRIs because I was doing this before CTs came out. Having CTs was the missing piece of the puzzle. So from my perspective, I can't imagine not having both. Because if I don't have the MRI, then I'm guessing at the cortical plate. If I don't have the CT scan, I'm guessing at the cortical plate stability. If I don't have the MRI, I'm guessing at disc position and the marrow space stability condition. From a practice management perspective, my profitability increased when I changed my diagnostic records to a bundled package that included MRI, CT, mounted study casts, and photographs, and a sleep screening when necessary, because that's really what I needed for the diagnostics. Now, once that fee got high enough, profitability increased dramatically, because now all of a sudden my assistants outproduce my hygienists every day. Because as you can create value for your diagnostic skills, that's where your practice changes. So my answer to the question is I'd like to have both. And if I don't have both, I feel like I'm guessing at one or the other. Next question, how do I get referrals from other dentists as I am a GP? Any marketing suggestions? Yes, make yourself known in your community. There are orthodontists, there are oral surgeons, there are general dentists in your community who, if they know that you're seeing joint patients, will send the patient to you as quickly as they can. Most dentists don't want any part of this, and as a result, for years, I had a small group that started out referring me patients. It got bigger, it got bigger. Now, I have no idea where a lot of the patients come from, simply because there's not many people doing this. If you can become the expert by imaging and understanding anatomy, the referrals will come. I promise you that. Does the mandible slide forward as we age, leading to lower anterior crowding and eruption and increase in sizal edge wear? I don't think it does, to be honest with you. I think, again, mandibular position is really dictated by the disc. If we have a normal disc, that gasket is going to position the condyle, and then it's simply getting the teeth to fit. If we have normal growth when we're young and we end up with a class 1 occlusion, usually we stay that way. I think if we slide forward, we always had a class 2 occlusion, and now we're just sliding forward. Great question about envelope of function and long centric, one of my favorite topics. Envelope of function is basically a non-restrictive anterior guidance, because an envelope of function is the chewing pattern. So what we want to do is we want to capture the chewing pattern through using provisionals to make sure they're not in the way. Then you can either, in the analog world, make a custom anterior guide table, or in the digital world, you can scan your provisionals, have them copy your provisionals. So either way. Long centric, boy, long centric's an interesting conversation. Long centric used to be thought of as closing slightly forward and hitting the front teeth. I think of long centric today as people who don't have the disc and they have a little bit more horizontal freedom at the joint level. That's not a traditional answer, but that's what I'm believing today. Does cervical disc herniation impact occlusion? I don't think we completely understand the impact of upper cervical spine on occlusion. I still think the primary determinant of occlusion is the joint and how the teeth fit together. So I'm not as tied into the neck being an influence on the teeth as I know a lot of other people are. What I do believe, though, is that the neck is its own pain source. And I do believe that a lot of times there's cervical misalignments in the neck that need to be treated on their own pathway, regardless of what happens in the joint. So I'm not sure if you treat the joints that the neck will get better. And I'm not sure if you treat the neck, the joints will get better. I think they're kind of on their own. We have a question. What are the problems that can occur in unilateral biting? You know, really, again, it's kind of what we talked about earlier in the program. It's about load distribution. What I want to try and do is to distribute the load over as many teeth as possible. The fewer the teeth carry the load, the greater the likelihood for some type of structural alteration at the tooth level. So that's why we try to get those spread out as best we can without overloading them in one tooth or one segment of the bite. And I think, Renelle, I think that about finishes all our questions here.
Oh, it looks like one more just popped up in the chat,
Awesome.
but we can call that the last one if you'd like.
Well,
Oh, I guess there's two more. I don't know.
is the poset envelope of motion the same as your envelope? Another good question. I'm going to tell you my understanding of that. My understanding is that the poset motion is the extent of the border movements that the mandible is capable of achieving. So it's the outer limits of where we can move our jaw. My understanding is that every patient has a unique envelope of function that fits within that. Our job is to try and capture that. Question is regarding ELF. Is therapeutics for a cant and TMJ? I have heard about the ELF appliance. I know that it is purported to do maxillary expansion. I don't use it. The patients who I have seen have not reported I guess the patients I've seen haven't reported the results that the appliance is purported to do. So I guess that's as much as I could say on that. I don't have any experience personally with it. All my experience would be from other dentists that I've talked to or from what I've heard from patients.
Looks like that's it for our Q&A.
And I think that's it. I want to thank everyone for taking the time out of their day to be with us today. Again, if I can be of any help, please don't hesitate.